me to print it off for you?
No, it's fine. Let's talk about leukemia. It's fine, I'll change the date. It's nothing you guys have to do, it's just an in-class activity. We'll do it on Monday. We'll break up the 3 hours on Monday.
I actually have a question. How, this might be a dumb question, but we were just talking. How do we like prepare ourselves for this exam with all this information?
I
you're getting?
will narrow it down. We're gonna review.
On what day? Like when? Monday or when?
We'll review.
Okay.
I'll prepare you guys, it'll be fine.
Because I was like gonna start today, so that's why I was wondering like when.
Yeah. Well, let's talk about leukemia. Your test is next Friday, right?
Yeah.
You'll have time. Have no fear. Okay, let's talk about leukemia. So this is a malignancy that affects the blood system, right? So you guys have probably heard about leukemia. Anyone know of anybody who's had?
My grandpa.
Your grandpa. Is he living? Died from leukemia. Do you know what type he had?
Well, no, I don't. He actually didn't die from it. It was something else. But yeah.
Okay.
But yeah, he had it for a long time.
Anyone else? So sometimes this is known as a childhood cancer because kids are pretty prone to get acute leukemia. So different types. So basically what happens is the bone marrow. So your bone marrow is responsible for making your white blood cells, red blood cells, platelets, right? You guys know that. So the bone marrow starts to produce a bunch of baby cells called blast cells, okay? So blast cells are what the body produces that are immature cells. They don't have an identity yet, and they then develop in either to a white blood cell, a red blood cell, a platelet, or whatever your body needs at the time, okay? So people with leukemia, these baby cells are very immature and they start to mutate and lose their DNA and misbehave, and they take over the body's system, but they don't develop into anything because they're mutating into a cancer cell versus mutating as they normally should into like a red blood cell or a white blood cell, okay? So when people are diagnosed with leukemia, what do you think is some of the first signs and symptoms that they present with, based on what I just said to you? The blood cell system is totally disrupted. So what is their CBC going to look like? Okay, they might have a really, really high white count, but they're not truly white blood cells in there. They're these baby blast cells that are clogging up the blood system and appearing like white blood cells. Okay, so they might have an extremely high white blood count. Their red blood cells might be low, might be more on the normal side. They don't tend to affect those right away. Typically, they can have really low platelets. So high white count, low platelets, classic sign of leukemia. So if somebody has a really high white count and really low platelets, how might they present? Or if their bone marrow is overactivated, how do you think they might present? Bone pain. Okay? Kids diagnosed with leukemia, some of the first signs is severe bone pain, nosebleeds, or idiopathic bleeding. So they have bleeding for no rhyme or reason because they don't have platelets to clot. Okay? So these cells, these abnormal leukemia cells, can invade into the liver, the spleen, and the lymph nodes. Okay? So they typically don't go anywhere else. They can get into like cerebrospinal fluid and cause neurological deficits, but that is definitely more in-stage cases. Okay, so you have all of these immature cells that are cancerous floating around in the bloodstream, clogging up the bloodstream. So if it goes untreated, it potentially can start to harm other organs, like your kidneys won't be able to excrete them. Okay, so it's classified by a couple different types, acute and chronic. So acute is the most severe, and this is what would be potentially take somebody's life. Chronic leukemia leukemias have a way different presentation and are treated way different. People can live a very long time with chronic leukemias. It's really treated more like a chronic disease, where a lot of times they give them oral therapy. They just help keep kind of their counts regulated. The people with chronic, it can potentially relapse into more of an acute phase. So that's really their biggest risk, is it turning into more of an acute leukemia. Okay, so usually this has a pretty acute onset if they have acute leukemia, so they may develop symptoms quickly. So they might be feeling really well, and all of a sudden they're extremely fatigued, or they have bleeding that doesn't stop, or they have this bone pain, or they're severely fatigued. In adults, fatigue is usually the #1 symptom. They'll be extremely run down. They might feel like they have the flu, and they just don't have any energy. Okay? There's also like myeloid leukemias. It just comes from a different cell called AML. A little more rare, but still common. More so adults tend to get AML, where kids will get ALL. It just is where this cell originated from, if it's from the lymphocytic cells or if it's from a myeloid cell. You guys don't really need to know that, but AML typically hits adults. ALL is more usually kids. And then obviously chronic happens more with adults later on in life. Okay, so it's uncontrolled proliferation of these myeloblasts, these baby cells circulating in the bloodstream, but they don't turn into the cell that they're supposed to, and they don't look like a normal blood cell, so the body doesn't get rid of it, right? Because it's not, they've mutated into their own cell. So it can cause hyperplasia of bone marrows. Remember, hyperplasia is just when there's too many of something that potentially can cause a problem. It can also cause hyperplasia of the spleen, because we know the spleen is also responsible for helping make and produce some blood cells, right? Like red blood cells are produced in your spleen. So the spleen is often affected as well. They can have severe neutropenia, so their white count can become extremely low. Thrombocytopenia, their platelets can be really low, so we have to worry about infection and bleeding. Those are definitely the top 2 things that are going to harm these people. They can also get bone infarctions, where literally the bone will die because these cells are so aggressive that it can actually cause an infarct to happen within the bone itself, which is very, very painful. Typically, people are diagnosed over age 65 if it's for adults. So CML is usually more common in women than men. It's a chromosome abnormality within the body. They're usually symptomatic. They might have decreased appetite, weight loss, or a fever, but usually pretty vague signs or symptoms. Typically, the chronic leukemias are caught more incidentally. So they might go in for a wellness check and have their yearly labs drawn and their white count is off. And usually that's how these chronic ones are diagnosed. They'll test to see is their spleen enlarged, which will mean sometimes that they've had it for a longer period of time. So sometimes they can tell based on spleen involvement, is it spread or not spread. These typically aren't staged like a 1 through 4. It's more staged as, is there spleen involvement, and is there how many blast cells they have at the time of diagnosis. And has it invaded into their, deeper into the spine, okay? So ALL is the most common in children and young adults. It's a very rapid onset. They, again, have these baby cells that are circulating and clogging up. So signs and symptoms you normally see in kids, they'll present with bone pain. They might wake up in the night crying that their legs hurt or that their back hurts. Well, sometimes kids can have just normal growing pains. So sometimes parents will put this off, like, no, it's just your bones are growing. But if it's severe or consistent, they should probably take them in and have some labs drawn. Nosebleeds is another big one. Like kids that have nosebleeds that won't stop because they don't have any platelets to clot, because all of these blast cells have basically ate up the platelets that they did have, and their body is not making any new blood cells because these blast cells are being taken over by the cancer. So They're not turning themselves into platelets or white cells or red blood cells like they should, okay? So bleeding is another huge thing. This has a very good prognosis in children for the most part. Usually it's an 88% to 90% cure rate in the 5 years if they get the appropriate treatment. So usually pretty good prognosis. We don't typically see kids still dying of this unless they have a chromosome or a specific genetic thing that makes it more aggressive, which is beyond what you guys need to know. So usually that prognosis is very good, but they have a long treatment. So they get 2 years. If it's a girl, they get 2 years of treatment, and boys get 2.5 years. And that's just because boys tend to grow a little more rapidly, and because of testosterone, studies have found that better prognosis if boys get treated for 2.5 years and girls get treated for 2 years. Okay, CLL, so same thing, they have these immature lymphocytes that are floating around. The symptoms are usually vague, has a very good 5-year survival rate. Most common in adults, and this younger adults sometimes can get this, but it's treated just like a chronic illness, basically. They have a very good survival. The biggest thing is to monitor that it doesn't relapse into an acute form of leukemia. Okay, so just some statistics. So obviously, lower cases, it's not as common. So some risk factors, children with immune deficiencies. There's been a direct correlation of kids with Down syndrome have a higher incidence of developing acute leukemia as children. And some of that is from, they already have a genetic kind of ding against them, right? They're missing some chromosomes. And they tend to not have as healthy of an immune system. So there's some research out there that shows if you have kind of a crappy immune system, you're more susceptible to cancer. Kids are the same. If they've had any previous cancer treatment, so especially breast cancer, the drugs for breast cancer, anthracyclines, those intense chemo drugs, can put people at risk of developing leukemias later on. Certain genetic disorders, cigarette smoking has been linked to AML. Some chemicals, so benzenes has been directly related, and then radiation exposure for both AML and ALL. When I was in Nebraska, there was a huge amount of population of people from like around the Columbus area, big farming community. So they had done a lot of studies like on their soil and their air quality to try to figure out why is there a huge population of people, both adults and children, getting diagnosed with so many leukemias in this area. And they couldn't really pinpoint it to anything, but just goes to show that there is some environmental risk. They think like a lot of chemicals farmers use, get in the soil, gets in the water system, all those things, potentially could put people at higher risk of developing blood cancers. So some symptoms that they're going to present with, sometimes they get swollen lymph nodes because, like I said, these abnormal immature baby cells can tend to migrate to the lymphatic system, so they might present with large or bulky lymph nodes. Sometimes a really high fever, and they can't rule out any sort of infection, but that's because they have all this activity in their blood system going on, so it can crank up their fever. They can have drenching night sweats, so they wake up in the night and they literally have to wring out their sheets because they're drenched in sweat. It's because their metabolism is revved up so much. Nosebleeds or bleeding somewhere else that they can't stop. So if like teenagers or women who are premenopausal, they could actually bleed to death from getting their period if they truly have leukemia because they might not have platelets to clot. So severe infections, bone pain, red spots on the skin that look like a little rash. What is that called? Petechiae. So that's just when the capillaries are breaking underneath the skin because they don't have platelets to clot. Pretty common symptom as well. And then unexplained weight loss and severe fatigue, I would also throw in there. Okay, so how is it diagnosed? CBC. So we're going to look look at their labs and say, okay, they have an extremely high white count, extremely low platelets. Suspect that they have leukemia, then they'll do a bone marrow biopsy where they take an extremely large needle and they're going to put it into the iliac crest, and they take a kind of screw, go into the bone marrow, and then they suck out bone marrow contents and they look at it to see, okay, have these cancer cells invaded the bone marrow? Very, very painful. Some oncologists will do this right in the office and will use simply lidocaine. I would not recommend that for patients. I would recommend for them to say, hey, take me to interventional radiology, have them give me some light sedation and let me sleep through this. It's very, very painful. They're literally digging or like screwing into the vein or into the bone, making a small hole and then sucking bone marrow out. And they say that patients will say when they like suck it out, they have this like extreme pressure, and that's almost more painful than the needle going in. So it's very, very painful for patients. Most places will do them under sedation anymore. Like in Mitchell here, they do all theirs and under sedation. The oncologists don't do them. But there is still some oncologists out there that will do them right there in the office. And patients with leukemia, they have these numerous times because that's how they know if their treatment's working, if when they look at the bone marrow, if there's no longer cancer cells in there. So, very uncomfortable. Plus, we have to worry about what? If somebody's having this done and they don't have any platelets, bleeding can be a huge risk. So you as the nurse, I have literally sat with someone and held pressure for like 40 minutes to get this to stop bleeding because they don't have any platelets. So sometimes they might have to give them platelets, give them clotting factor before they can actually do the bone marrow biopsy to get a diagnosis if their platelets are that low. Okay? So here's an example of somebody's lab values who's diagnosed. So what do you see in that? White count, if somebody had a white count of 56,000, would that be alarming to you? Now remember, this isn't all white blood cells. Some of that is these blast cells that are cancer cells circulating in their blood that show up as white blood cells, but they're really these premature baby cells that are just causing damage. Okay? Red blood cells aren't too bad. Hemoglobin is a little low, 7. Okay, hematocrit 25, platelets of 35, that's not terrible. Okay, I have seen patients diagnosed with white counts like in the 100,000s, and they come in and their platelets are 6,000. They literally have no platelets to clot, and their white count is through the roof. Okay, when do we usually give people blood transfusions? If their hemoglobin's a little what?
6.
Usually 8 is the cutoff. In the cancer world, sometimes they'll wait till they're 7, or if they're symptomatic. What do you think we transfuse platelets at? Sydney says 30. What do you think, Hope?
Actually, it's like
7 to 10?
7.
Oh, 10 for platelets. So in the oncology world, they can have plates of 10,000. That's pretty severe. In the regular world, if somebody's platelets are less than 20, typically they'll transfuse platelets, 20,000, okay? In the oncology world, sometimes they're lower because if you had a person with true acute leukemia, we could give them all the platelets in the world and the next day they're still gonna have none because those blast cells are going to suck them up and destroy them faster than the body's going to use them. So very high risk of bleeding, okay? They will get large amounts of chemotherapy and very high doses, well, I shouldn't say high doses, but very strong chemotherapies. Okay, so anybody who has an acute leukemia diagnosis, they are admitted to the hospital right away. It's not go get your affairs in order and come back next week because this can turn very into a medical emergency very, very quickly. If somebody has no platelets and they have that amount of white blood cells floating in their system. So we have to give them chemo right away. So they do what's called induction where they get very high doses. They repeat the bone marrow biopsy, see that there's no more cancer in there, and then they put them in kind of a post-remission and they get consolidation chemo. Not something you guys need to know, but just they get very, very large amounts of chemo, they become very, very sick. They're usually in the hospital. These are patients you will see in the hospital on the oncology floor getting chemotherapy. And they get very high doses, okay? They can also get like interferon. So on that chemo or that pharmacologic video I showed you guys, it talked about interferon, a very horrible drug, causes horrible side effects. So sometimes they use it for leukemia. They typically don't give them radiation therapy unless they have a lot of bone marrow involvement, and sometimes they'll do like whole spine radiation. They don't do that as often, but they can. They also, if they fail standard chemotherapy, there's a new therapy out there called CAR-T therapy, which is where they use the patient's own T cells, mix them with the drug, and re-give them back to them, and then it basically is their immune system on steroids goes and fights it. And this is allowing people to survive who otherwise would have had no chance of survival, or they would have ran out of options until about probably 5 years ago. CAR-T is really new in the world, and it's going to probably, at some point, maybe be used for more of your like solid organ tumors, like lung cancers, other areas where truly the body's T cells, your fighter cells, are fighting off the cancer itself. So CAR-T therapy is new, it's very exciting. They don't know how long these activated T cells last in the body, so that's kind of interesting as well. They're prone to a lot of those itises, so like gastritis, colitis, it can affect their thyroid. Usually it damages their pancreas and they become dependent on insulin long term. So a lot of issues with CAR-T, but it has done a lot of really good things. Okay, they can also have what's called a bone marrow transplant. So if they have these cancer cells floating around in their bone marrow and they've done chemotherapy, then they can take someone else's bone marrow, put in their healthy baby blast cells, and basically it tricks their body to say, okay, we're gonna make only healthy cells and no more cancer cells. So this is something that used to be used as kind of a last case scenario. They don't do these as much anymore because with CAR-T and some other options, and there's a lot of risks for people who are having bone marrow transplants. They get very, very high doses of chemo. It kind of wipes out all of their good cells. They have to stay in the hospital for 100 days, and there's a lot of risk afterwards. So sometimes they'll have this after they've been in remission, and it prevents it from ever coming back. They don't usually do this with kiddos, more so in adult leukemias. So allo means that they get a donor from somebody else, so a sibling or somebody who has a similar blood type, or autologous is their own stem cells. So once they don't have any cancer anymore and they're technically in remission, they can have their stem cells removed, and then once they're fully in remission, they can give their stem cells back to them with the idea that they'll hopefully grow into normal healthy cells. Alright, we'll stop there because I feel like I'm losing this.
Donor from
We'll
someone
continue talking about
else.
this on
Yeah,
Monday.
and then that's donuts.
Their own
Send
cells.
We'll do our activity
Patients
on
in remission,
Monday.
they take them out and.
We'll talk about prostate cancer on Monday. And we'll talk about skin cancer on Monday. I know that sounds like a lot, but honestly, the skin cancer is not a ton of stuff. It's stuff you guys have heard before, like benign squamous cell, basal cell skin cancer, right? We talked about those in assessment before. And then melanoma we'll talk about.
How about